Good morning. Thank you very much for turning out. I'm very impressed that you would all want to come 9 o'clock on a Saturday morning to learn about the new Cambridge Cancer Research Hospital, but we're absolutely delighted that you are here. My name is Professor Rebecca Fitzgerald, and I'm joined by my colleague, Professor Jean Abraham. We're both clinicians and academics working on the biomedical campus, and we're both very involved with thinking about the future of research on the campus, in cancer in particular, and what we might do, the opportunity we have through the new Cancer Research Hospital. So we're going to divide this into two. I'm going to start off, and then I'll hand over to Jean, and we very much hope that we will have timed it well, and we'll have some questions at the end, and there'll be a roving microphone for that. The event is being recorded, I'm told, so if any of us aren't happy with that, including Jean and myself, but we've agreed we're happy with that, then please let us know or leave now, I guess. But it will be being recorded. So, how can we change the story of cancer? That's really what we're thinking about in Cambridge with this new Cancer Research Hospital. So this has been quite a long journey. And many of you may be familiar with the Addenbrooke's campus, now a really sprawling, thriving biomedical campus, but the original hospital estate is quite old, going back to the 1970s, and we have a number of challenges, particularly around the age profile, the clinical infrastructure and some risks around that, the sustainability, our capacity, and the ability, therefore, that we have to deliver really high-quality care. Now, when the NHS was founded, the whole concept was that research would be part of what we do in our National Health Service, and very much that's what we embrace in Cambridge. But nevertheless, there's a lot of work to do to really integrate the research into routine clinical care, rather than being it something that's available for a few privileged people who know about it or who ask about it. And also our researchers are in separate buildings by and large, and some of that is necessary compared with the hospital, but it can sometimes lead to a kind of two separate communities rather than it feeling like one integrated community, all ultimately working for the benefit of patients. So since 2014, there's been 2010, and then really starting to develop in 2014, starting on a journey to think about how we can redevelop the campus. Of course, this is mainly about cancer today, but also this effort is around children's facilities and neurosciences. This has gradually picked up pace, and we now have, in December 2021, initial approvals, then the REBA 3 design work complete in December 2022. In May 2023, there was an announcement that funding was agreed to move through to go forward with this national plan. And we are starting to make real concrete plans now to begin construction in 2024 with a pledge for government to underwrite this whole endeavour. So this is very exciting, a long journey that is now really happening. And just to give you a flavour of the biomedical campus, I've trained in Cambridge as a medical student, so saw it in the early days, and it's just absolutely unrecognisable from the late 80s, early 90s. Well, now we have this fantastic grouping of hospitals, research facilities, and industry, as well as biotech. So we have the Heart and Lung Hospital campus, Papworth, which moved, and that's this big round building, seemed to be the flavour of the day. So this big blue round building here is the Papworth Heart and Lung Hospital, with the original Addenbrooke's Hospital just behind. So number 4 is the original hospital. The other big round building, so I don't know if the pointer's working, number 5, is the AstraZeneca R&D headquarters. And the big square building in the middle, this is not yet built. This is what we're talking about today. This is the plan construction, so you can see where it's situated for the new Cancer Research Hospital. The building I am in is number 2, which is the Early Cancer Institute, which I'm going to tell you a little bit about. And Jean is in the CRUK Cambridge Institute, So both of these are very close by to what will be this new Cambridge Cancer Research Hospital. And as I've said, the whole concept behind this is a very tight integration of research and clinical care. So the clinical cancer services will include ambulatory care, inpatient cancer wards, diagnostics including radiology, and a bespoke teenage and young adult cancer ward. But integrated within this same building, we'll have an Early Cancer Institute research clinic, which I'm going to tell you about, and then an Institute for Integrated Cancer Medicine, which Jean is going to explain, as well as a Precision Breast Cancer Institute. So research and clinical care right next to each other. And AstraZeneca will also have space within the building, so a translational research unit, which will be next to the Early Cancer Institute research clinic. So the idea is to change the culture, not just to lift and shift. So there's a lot of thinking going on with a whole transformation work stream to think about how we actually make a difference and bring research into the heart of service delivery. How do we manage research across a distributed service? And what are the opportunities we've got to revamp digital and other pathways? So I'm going to tell you a bit about some of the science we're doing as well, because I think, at the end of the day, it's about the science, not just about the buildings and the facilities. So I'm going to tell you about the Early Cancer Institute, why early cancer is so important, some examples of the kind of work we're doing, and how we see this flowing through into the hospital. And then I'm going to hand over to Jean to talk about breast cancer and integrated cancer medicine. So as clinicians, when patients present with cancer, we do a lot of investigations, particularly imaging, and we give the cancer a stage. And that helps us determine what kind of treatment is appropriate, but it also has a very big impact on the prognosis. So for all cancer types, we tend to use this staging system, which groups patients into stage 1, which is early, through to stage 4, which is late. And the 10-year survival, as you can see, is dramatically different depending on the stage at which you have your cancer diagnosed. And the unfortunate thing is that often the symptoms that cancer leads to can be quite vague. Things that we might ignore. I think as the British public too, we're sometimes quite reticent to go and bother our doctor. There may be delays in the diagnostic pathway, and very often the stage of diagnosis is, most of the time, over about 55% of the time, stage 3 and stage 4. And in the research institute that I'm directing, we're particularly focusing on poor outcome cancers, and I've listed some of these here: pancreas, lung, esophagus, liver, and acute myeloid leukemia, which all have very poor outcomes. And so the 5-year survival is given in those percentages for those cancer types. And a lot of that is due to this late diagnosis. Now, of course, it's easy to get hung up on survival, but it's not just about survival, it's about the kind of treatment you're having to go through and the quality of life and the side effects. So if you can diagnose it early, not only are you likely to be cured and live longer, but the treatment you're going to have to go through is often very much more simple, less toxic. Sometimes you can just cut the area out, no chemotherapy, and so on. So it also makes a big impact in terms of your quality of life. And also from the health economic point of view, it's also for the health service much more manageable and sustainable if we're diagnosing cancer earlier. And this is why this has become a major priority. This isn't just in the UK, it's a priority globally now, but a real focus on earlier diagnosis. I've been interested in early cancer and how cancer evolves for the whole of my career, but it's been rather a Cinderella topic actually until fairly recently. Because if you think about early diagnosis, it gets quite complicated quite quickly. You have to start thinking about population efforts, not just individual efforts. And as soon as you start thinking about populations and screening, you then have to start thinking about false positives, as well as the true positives and what the downsides of those endeavours are. So it is a complicated topic, but I think now that we have some real political and funding going into this stream, and the tools, the technology that means we can start really looking for very early changes with much better resolution, means that this is a ripe area for research. So part of the NHS long-term plan and the life sciences industrial strategy. So what kind of things from a scientific point of view do we investigate to understand why some people get cancer and therefore, of course, what we can do about it. So cancer actually evolves over many years, often decades. As our tissues age, we accumulate mutations, abnormalities, and so in many of our tissues, we get early precancerous lesions. So that's these pre-invasive solid lesions. So if you look hard, you can start to spot these. The trouble is, if you look hard enough, you'll also find just normal aging problems which are not going to give you any illness in your life. So if you look at your skin, it's actually a whole patchwork, if we look at a molecular level, of these patches of different mutations, most of which are just normal aging skin. So we have to understand what are the consequential versus the inconsequential problems. So there are precursors to blood cancer as well. Some of us are genetically predisposed to cancer. We'll be familiar with BRCA mutations in breast, but we're now knowing there are many mutations inherited which can increase your likelihood of cancer. We expose ourselves to all sorts of things, bad habits, smoking, drinking, too much fat. Fatty liver is an issue, which I'll come to in a minute. Infections like human papillomavirus. And this is one of the great success stories of preventing cancer with cervical cancer, which the WHO have now announced we can eliminate worldwide because we have the vaccine for human papillomavirus. So just to give you an example of my own research, so I've been particularly interested in cancer of the esophagus or the swallowing tube, which has typically been diagnosed by an endoscopy. And most patients don't get an endoscopy until they've really got a serious problem with swallowing. And the risk factor for this kind of cancer is heartburn. And heartburn, reflux, is a very, very common symptom. You can buy the pills over the counter at the supermarket, the petrol station, to control your acid reflux. Most people with those symptoms will never get an endoscopy. So we need something much simpler if on a population level we're going to find the precancerous condition, which we know is the forerunner of this esophageal cancer called Barrett's. So I set about trying to devise a really simple test, and this work actually goes back 20 years, and it just goes to show how long it takes to go from a kind of concept through to implementation. And we developed this sampling device, which is an incredibly simple thing. It's a little pill on a string. So it's a capsule, and within the capsule is compressed a sponge. So you swallow the capsule on the string. The capsule dissolves over 5 to 7 minutes. Out pops the sponge. The nurse pulls it back, and you collect 1 to 4 million cells, which you can then send to the laboratory. And we made a number of different laboratory assays which can detect the needle in the haystack and find the precancerous cells. So simple enough. But you can't then just take that concept and try it out immediately in the NHS. You have to decide who is your at-risk group that you're going to test. So this is people on medication for reflux at an older age. And then you have to set about gathering the evidence to show if this is accurate and does what you think it's going to do. So we did 3 large trials going from proof of concept through to a randomized trial, the best 3 trial, to show whether this technology works. And in the 3rd trial, we were comparing GP usual care with offering this cytosponge test, and what we showed was that offering this test would diagnose 10 times more precancer than GP usual care. So the quality control and the lab testing is obviously very critical. So we developed a spin-out company called Cited to deliver a centralized service for this cytosponge test. We set up the company in 2020. Just before the pandemic, which proved to be very fortuitous because NHS Scotland phoned me up just as the pandemic was really ramping up, and they said, we've heard about your test cytosponge, we're really, really worried. What are we going to do during the pandemic with our endoscopy waiting lists? These patients are not going to get an endoscopy. Do you think cytosponge can help? And I said, well, we're still gathering the evidence. We haven't really developed it. We've developed it for screening, we haven't really developed it for people on NHS waiting lists who have got symptoms. But given COVID-19, maybe as long as we evaluate carefully, this would be a reasonable thing to do. So we rolled out cytosponge into NHS Scotland, followed by NHS England. And we've now done over 16,000 tests as part of this implementation pilot, which is being monitored as we go along to see whether this could be routinely introduced into the NHS to help with endoscopy bottlenecks and improve the diagnostic of early disease. And this is relevant because always the question is, well, if you find something, what can you do about it? But we now have fantastic endoscopic therapies, no chemo, no operation to remove your esophagus if we find it early enough. We can literally remove it down the endoscope. We haven't quite finished our trials yet because we went to the National Screening Committee and said, could we roll this out as a national screening test? We've now got all this experience in the NHS and so on, and they said, well, that's fantastic, but for a national screening test, you need to show not only that you diagnose more cases, but whether you reduce mortality and morbidity through your screening program. Now, this is why people shy away from early cancer research. To do that kind of trial means randomizing 120,000 patients and following them up for 10 years. So we're just setting up that trial now. We've got funding from CRUK and NIHR. We're starting in January to see if we can collect that evidence and really find out whether this would be fit for purpose as a national screening test. So I think we're in a new world of finding cancer early and precisely, and there are different ways we can do that. We can, for example, if you take breast screening, we can, rather than just offering breast screening to everyone over a certain age, we can be more precise about thinking about an individual's risk, and some women who probably need very little breast screening and others who need more, or maybe they need it in a different way. Perhaps we can detect multiple cancers at the same time with multi-cancer blood tests. This is a very hot topic. Technologies are now developing to detect DNA in the blood that could be a signature of multiple cancers, not just one at a time. And this is a bit scary, and I don't know if we would think this is a good thing or a bad thing, but what about in your home? If you don't have to do anything proactively, but there are sensors in your home monitoring whether your temperature's gone up a bit. I was talking to someone yesterday, you sit on the toilet seat, it can read out your heart rate, your blood pressure, whether your weight has changed. Maybe you'll look in the mirror, it'll tell if your facial appearance has changed, and then it'll tell you when you need to go and see the doctor without you doing anything. I don't know about that. So I think my time is, how are we doing for time? Nearly up. But let me just tell you a few things about the Early Cancer Institute. So this is the UK's, this is new. We launched it in September last year. We've repurposed this building to really focus on early cancer. We brought together a new group of researchers who are specifically focusing on the kind of things I've been telling you about, how we understand how cancers evolve, predict and prevent cancer. So we have three main strategies: risk prediction, detection, and interception. And these are our group leaders. 6 of us are clinically qualified, which gives us really, I think, a very helpful clinical perspective on the problem. And then a multidisciplinary approach as well, so working with people across physics, genetic epidemiology, imaging physics, and technology in genomics. Serena Nick-Zenal is using big data from DNA sequencing to really understand mutation fingerprints of tumors and understand how you could use that to detect cancer earlier. And the incredible thing is, through our Federated National Health Service, and this is relevant to the hospital, you can really collect data on a massive scale from genome sequencing and health, all the data we have in our electronic health records these days that can now be integrated together with sequencing data, environmental data, what treatments you're having, to then use that information to risk stratify in real time and make new algorithms for early detection. So that's what Serena is doing, working with Genomics England. Jamie is a physicist, and he's trying to understand the evolution of cancer using mathematical approaches to understand how a cancer is born and evolves. Because usually when we diagnose a cancer, we're here at this right-hand side. From a molecular point of view, it's very complicated. It's like a branching tree. It's a Darwinian process of evolution, and by the time we diagnose the cancer and we try and understand where it came from, it's quite a complicated picture. But if we can go back in time, we can start seeing how it started in the first place. Right, even from when we're born, our tissues, right from that moment, start collecting abnormalities. And those cancer traits, it turns out, when you start studying them, are laid often decades before the cancer. So you can start to go back in time if you have the samples and then work out at what point you could have detected it and intervene if you had had the tools to do so. So he's been using blood samples from the big cohort of women collected over many years for an ovarian cancer study, but some of them developed acute myeloid leukemia. And he was able to go back and look at their blood samples like a kind of archaeological record and pinpoint the different clones of cells, groups of cells, and the mutations that they have, and work out decades before the diagnosis was in their 80s, could we actually find what these different mutations are? So those different coloured lines are groups of cells with a mutation that are growing up through the blood. So actually, when this patient was in their 10 years earlier, in their early 70s, we could already see these blue and red clones starting to expand. So potentially, if one had known what to look for, you could have found them earlier. And Caroline Watson has just set up her laboratory in the building. She's a hematologist, so a clinician working in tandem with Jamie, so she can start to think about, okay, if we know how these different leukemic groups of cells are growing, why is it some progress to cancer quite quickly, some more slowly, some don't progress at all, and what could we do to stop them growing or to intervene? Matthew Hoare is a hepatologist, and he's trying to understand why fatty liver causes cancer. Liver cancer is one of the fast-growing cancers globally, and one of the main issues behind that is diabetes and obesity. And he's worked out by examining cancerous livers that many of the mutations, shown in that complicated chart at the top, those are all different genes, they all seem to be acting on the insulin pathway. So it's telling us something about what's causing these cancers to develop. And so he's starting to do studies on a population scale across Cambridge and Portland, because we've got a nice collaboration with Oregon, to try and really collect enough samples to understand what's happening between diabetes, fatty liver, and liver cancer, what the causes are, and whether it could be preventable, and working with AstraZeneca as a partner to think about treatments. This is a new company that's been spun out from the Institute, and also a big collaboration with Cancer Research UK and the ACE Alliance, to say the immune system we have is an incredible inbuilt detector for all sorts of things, for infections. It spots cancer as well. Sometimes the immune system just mops up a little cancer, sometimes it doesn't succeed. But what if we could use the immune system as kind of our own spy and read out what it's seeing to understand if that could be a detector? So that's the work we're doing in the Early Cancer Institute. I think we've got a very dynamic set of new group leaders really thinking about the underlying science for cancer, but then we want to translate it through into clinical studies and ultimately help patients. We currently do that in a clinical research facility, but we're hoping to bring that to this cancer research hospital. Our early cancer clinic will be on the top floor of the new hospital, which I'm very happy about because it means we'll have a fantastic view. And we're juxtaposing engineering, prototyping labs, tissue culture wet labs into one place alongside a training suite for endoscopy, space for hotel space for biotech, academic industry partnerships, so we can really have an entrepreneurial culture. And the whole idea is that we can shorten the pathway from research to implementation. And AstraZeneca are going to be co-located on that floor as well, and these are some of the things that they're excited about working with us on. So let me hand over to Jean to tell you about later on in more advanced cancer what we're doing.
Hello, can you hear me all right? Excellent. Well, thank you to Rebecca for that excellent introduction and whistle-stop tour of early detection. I'm going to tell you about two institutes that are in the hospital. One is called the Precision Breast Cancer Institute, which I will be currently direct and will be in the new hospital. This is what our Precision Breast Cancer Institute aims to do, and you'll see some echoing of themes across both early detection and also the breast cancer program and also the integrated cancer medicine theme. And really what we're trying to do is bring the work that's done, the amazing work that's done in Cambridge and elsewhere on the basic science side into the clinic and to the patients quicker, because a beautiful paper in Nature is not enough. It has to come and affect every patient's care in the clinic. So what we're trying to do is develop an integrated clinical translational platform, and we want to improve the survival. How long does our patient live and what quality of life do they have when they're living it, and for longer, and actually understand for each different type of breast cancer how we can do that. We want to reduce treatment. So when you hear about precision medicine, it's always about more treatment, new treatment. It's all terribly expensive, but actually it's also about not giving treatment if you don't need it, avoiding toxicity where you can. And I'll show you some really good examples of that. On the basic side, we're really trying to answer the critical questions that my patients ask me every week by looking at the biology and the biology networks that interconnect with those questions. And we're trying to identify that in the different subtypes of breast cancer, but also in the different time points, because the changes that you see at the very beginning of your journey in cancer to if you're unfortunate enough to relapse are quite different. And then again, if the disease spreads more widely. So there are big differences there and differences in the science and basic biology as well. So if you look at your far left-hand side, the questions, those 6 questions are the questions that I am asked every week in clinic. They are the questions that burn in someone's head when they are told they have got cancer. The one that's often not voiced but is always in the background is, am I going to die? Followed by, how will I be treated? When will I know if my treatment is working? Will my treatment make me ill? Do I need more follow-up or more treatment while I'm being followed up? And importantly, are my family at risk? So these are the weighty questions that someone is challenged with when they're diagnosed with cancer. And they're translated pretty easily onto clinical questions that we're asking as clinicians and clinician scientists. So when I was a medical student, people used to put graphs like this on the screen, and then they used to witter on about it, never really explaining what it was. So let me be clear. This is called a Kaplan-Meier curve. It looks terribly complicated. It isn't. On the y-axis, so up here, it's telling you about how long someone lives. At the beginning, at point 0, everybody is alive, right? On the bottom, the x-axis is time. Time is always on the x-axis. And what we're saying is each of these coloured lines is a different subtype of breast cancer. And each of these breast cancers, the people with those type of breast cancers will die more quickly or more slowly over time, depending on the subtype. And the one that's shown at the moment is the pink one. And that is what the type of breast cancer that you most often see when someone walks through the door. 70% of patients have estrogen receptor positive breast cancer. And that just means they've got cancer that really enjoys estrogen, likes to be in an estrogen-rich environment. So we see a good number of people with that pink line. And what you can see about that pink line is everyone's alive at the beginning, but actually over 12.5 years, not that many people die. Actually, most of them are alive. The unfortunate problem is that a woman who comes in with this type of estrogen receptor positive breast cancer in clinic looks identical. So we can't tell the difference between that patient, who's going to survive really well over 12.5 years, and this one, where actually 60% of the patients are going to be dead by 8 years. So how do you tell the difference? You can only do that by looking deeper at the molecular pathology, the pathways that interconnect, and many other things. You can see it again. We have a breast cancer subtype called triple-negative breast cancer, and all that means is you can't treat them with hormone therapy, you can't treat them with targeted therapies for a protein called HER2. So there's very few treatments you can give for these people. And in those patients, the pattern's slightly different. So it's the purple line, so at the beginning everybody's alive, and then there's a crashing loss of life in the first 3 to 5 years. So if you can get some good treatments in those first few years, you can actually cure these patients. Because if they make it to 5 years, they actually live for ages. So that's very different from the other 2 breast cancers. And again, I'm sure you've heard about immunotherapy coming into breast cancer and other cancers more recently. And the turquoise line are patients who, again, have a slightly different pathway, but they are very prone to be treated with immunotherapy. I thought I'd just mention the brown line. The brown line is the one right at the bottom where most patients are dying. Now, this data was collected before we started using a drug called trastuzumab and many other drugs that have come along following that. And it's for a type of breast cancer called HER2 positive breast cancer. And since that drug has been used routinely, these patients with the brown line are now somewhere up here where the pink patients are. So it's made a massive difference. It took nearly 15 years from finding the protein and identifying how to inhibit it to actually getting the drug into clinic. So which again echoes back to what Rebecca said about getting work from the bench into the bedside and to the patient. So one of the key focuses that we have in our institute is to make sure that the research that we do all the way along from the beginning is thought about translating it into the clinic. So this is the personalised breast cancer programme, which I set up probably in about 2015-16. And it's for breast cancer patients of any stage and any age and any subtype. And initially it was run in Cambridge, and you come to clinic, we offer you the study. If you're interested, we take a piece of tissue from your tumour and we take a blood sample. And we extract what's called the RNA and DNA, and we do whole genome sequencing. I will explain that in a minute. We set up a specialist board to review the results from these tests, and then decide what kind of things are important to look at, and then decide, most importantly, what impact it has on the cancer management for that particular person. So, whole genome sequencing. How many of you have heard about sequencing? Yeah, it's everywhere, isn't it? You can see it in all the broadsheets and others. So, whole genome sequencing is the process of reading your DNA, or actually your RNA. And your RNA is the thing that converts your DNA, which contains all the material you need to be you, into proteins that build up the cells, etc. Obviously, this is a terribly simplified explanation. I want you to think about sequencing a bit like reading a book. All right, so in the old days when we did sequencing, we'd pick our favourite genes, we'd pop them on a panel, and we'd sequence them because we knew those genes were important in breast cancer. That's a bit like going to a book, picking up the book, looking at the front page, looking at all the chapter headings and the back page and going, right, I've got an idea about what this book's about. Gives you some detail, but it doesn't really give you the depth and detail that you need. So whole genome sequencing, actually, you sit down and you can read the genome in different ways. So if you're sat waiting for a train, you're going to read your book, but you know you've got to get up in a minute, so you're going to read it in a fairly light touch way. You're not reading it in detail. So read can be in great detail, it can be many times, so it can have depth or it can be shallow. And you can read it once or you can read it many times. Whereas if you're at home, you've got a box of chocolates, lovely cup of coffee, you've got your feet up, the sun's shining, books open, you read every page, you read every word on every page. And so you read it in depth. The genome is like that. So you can read it in great depth, you can read it many times. The more times you read the genome, the fewer mistakes you make when you're extracting the information. All of that obviously costs money. The second thing is cancer has got two genomes. It's got what we call a germline genome. We look at that in the blood. That's what you inherited from your parents. It's what you'll hand on to your children. And then it's got the somatic genome, and that's what has changed in the tumour since you arrived. You could get losses or gains, so areas of the genome that's been lost or there's too much of it, and many other types of variation. The main problem is that you get a whole heap of information, and the richest people in Cambridge in the science field at the moment are bioinformaticians and computational scientists, because we have so much data and we really need to understand how to understand it and use the right bits of it. So, as I said, the key thing for me was to make sure that what we did impacted on patients. So the first part of this study was purely about, can I take a biopsy and get a result back to the patient in 12 weeks? And we chose 12 weeks because that's 3 cycles or 4 cycles of chemotherapy in breast cancer. It's usually a decision point. So we wanted to get the information to the doctor by the time they were making a decision. Actually, we do this in about 6 to 9 weeks now. And we've done this now for 1,300 patients. And I'll tell you a little bit more about the progress of it in a second. But it performs 2 things. It gives us a real-time readout and how it impacts clinical care, but it also creates a legacy for research. And so we've got PhD students who are studying on this, postdoctoral candidates who are studying projects on this, and it's allowed us to collaborate globally as well. So what benefits does it give you? So it can identify hereditary carriers of genes that need to be screened for and given preventative treatments for. Our rate of referral to genetics has almost doubled. And of course, that has an implication for the NHS. You've got to resource that kind of increase in referral. There's an opportunity for people to make decisions about prophylactic or preventative treatments and operations, and identification of the family risk. Who else in my family needs to be screened for cancer? And then there's more complex clinical things like getting people into trials that are more appropriate for the type of mutation that they've got, changing the standard of care treatment based on the mutational signatures that we see, and actually identifying people who've got problems with how they handle the drugs that might have a great deal of toxicity if you give them the wrong dose of drug or the wrong drug. And as a very quick glance, about 30 to 40% of our patients actually have a change in their clinical management. So that's all lovely, but let me give you two real people who've been affected by this. The patient at the top is 69, the patient at the bottom is 68. They both have triple-negative breast cancer. Doesn't respond to estrogen therapies, it doesn't respond to HER2 targeted therapies. Not many options for treatment. The first lady came along, she's 69, so by standard of care in the NHS, we do not test her for BRCA or high-risk genes. She's too old. And the reason she's too old is because the level of pickup rate for BRCA is low once you're over a certain age. So at 69, she's not going to be checked. But in this study, she gets checked, and for her personally, it means that she can make a decision about whether she wants to have prophylactic surgery and other types of screening for her ovaries, etc., that she may want to undergo. But for her daughter and sister, they were actually identified as carriers. So for them, they can now have regular screening so that if they look like there's any changes, they can have a treatment done so that they can actually have their disease managed and identified early, exactly as Rebecca's been talking about. For the patient herself, we could reassure her that despite any problems she may have had with side effects, she's on the right course. And in fact, this lady was treated in 2016, so she is now 7 years disease-free. And for that subtype of breast cancer, it's the one where there was a sharp drop quickly, she is very unlikely to relapse from her cancer now. So effectively, she's cured. The lady at the bottom actually had a deletion in a gene called PMS2, and that is actually more commonly seen in colorectal cancer, but occasionally seen in breast cancer. So she had a syndrome called Lynch syndrome. So she had to undergo a whole load of different screenings. So colonoscopies, was given aspirin to prevent the occurrence of colorectal cancer. She also had other types of testing as well. And 5 members of her family were tested, and 2 additional cases of Lynch syndrome were found. So they will now go through the same kind of screening mechanism to try and find disease early if it happens. And again, for her, she had a mutational profile that showed far, far too many mutations compared to normal. And that means that she's probably going to be likely to be receptive to immunotherapy. Now, at the time, she didn't need it. She actually is now 7 years free of disease without immunotherapy. But were she to relapse, we know exactly what we're going to give her. So one of the problems we have is when someone relapses, how do you know what to give them? Whereas this lady, we know exactly what to give her. So I told you earlier that the impact of our institute is looking at is not just at giving more expensive drugs more often. It's about reducing treatments. And 2 of my colleagues, Helena Earle and Charlotte Coles, did trials in targeted therapy in HER2 breast cancer and radiotherapy, respectively, in which they looked at regimes where they carefully reduced the amount of treatment that a patient was getting to see if they could still get the best outcomes for those patients. And they found that the answer was yes. And that's allowed a worldwide change of global practice. So low-income countries that can't afford to give 12 months of a particularly expensive drug can now say, actually, you don't need 12 months. This study says we can reduce that to 6 months. So that's been really helpful. Same for the radiotherapy. And it's underpinned a global de-escalation in therapy that's reduced costs in the NHS and savings of about 46 million pounds every year. So that's pretty impressive. So it's not just about more, it can be about less, carefully. The Institute for Integrated Cancer Medicine. So I'm going to explain to you first of all what integration actually means. So integrated cancer medicine, what does it mean? So you can aggregate data. That just means you bring it all together and you collect it and you put it in a format that's computable that you can actually work with. And then you need to combine that data. So every time you walk into a hospital, someone will take a history off you, you'll tell them your story, you'll have a blood test done, you'll have some imaging done, you might have a sample taken of some kind. You might go into a research study, you might go into multiple research studies if you're treated in Cambridge. All of these bits of information about you are held in different places, and we don't maximise what we're taking out of that information to really make sure that we're treating you well enough. So putting the sum together so that the sum is greater than the individual parts, and understanding what data is important when and why is really critical, and understanding how the different data impacts on each other at different time points as well. So this is where we are. So this is level 7, not quite as good a view as Rebecca's got, but not bad. So the breast, we have an NHS breast unit, which is the lighter purple, and below is the Precision Breast Cancer Institute. And then the mauve-coloured area is the Integrated Cancer Medicine Institute. And that's responsible for taking assays that are made in research and converting them into assays that can be used in clinical practice. All the research groups in there will be looking at integration of different types of data to create tools that can be used not in Cambridge. There is no point building a millions of pound cancer research hospital if the only people that are helped are the people in Cambridge. Because frankly, you're all treated pretty well anyway if you live in Cambridge. So what you want is a hospital that can impact locally, nationally, regionally, nationally, and globally. We're making tools that you can sit in Liverpool, where I'm from, and use those tools just as easily as you can if you're sat in Cambridge. So those kind of tools that will predict for response to treatment, to look at how well someone will do overall, and also improve clinical trials. This is an exemplar study, so we've just been given £6.5 million by a funder that I can't name yet because it's not publicly released, to actually bring together these different types of data and start to build different tools that can tell us these different things. So that question of, will I respond to my treatment? The idea is that before you've had 21 weeks of therapy and your surgery, actually by about 6 to 9 weeks, we can tell you, actually, you're not going to respond to this. We're going to do something different. So that's the kind of thing that this project will do. And this is the kind of tool I'm talking about. So at the moment, we use a fraction of these different modalities, clinical, radiology, genomics, and pathology, and ctDNA is that circulating small bits of DNA that help us detect cancer early that Rebecca's mentioned previously. And we're bringing that all together, and the idea is that by telling someone about whether they'll whether they'll respond or not to treatment, you can either change their treatment, take them to surgery, or stop the treatment, depending on what's needed. Similarly, when we are reviewing patients in a multidisciplinary team meeting, the data's everywhere. It's in different hospitals sometimes. We have to bring it all together to make that functionality better. Again, we're using integrated cancer medicine. So what we hope by doing integrated cancer medicine is that we can improve precision care for patients, reduce toxicity, and actually make it easier for the researcher to do their research and develop things that can help doctors, nurses, and researchers in terms of time and money. I think I will stop there and leave you to watch this. Now, I don't know if on the screen, don't I? I can't do it that way, can I? No. You can have a soothing video at the end.